Ashish Dash, consultant rheumatologist at the Institute of Neurosciences, Kolkata, and Dr. Arup Ghosh, assistant professor at Calcutta Medical College in the Department of PM and NAR.
Sero-Negative spondyloarthritis treatment and work. What to Dr. Das?
Good afternoon. I will be speaking mainly on the treatment overview, and Dr. Arup Ghosh will be speaking on the actual rehab part. We know that axial spondyloarthritis is a chronic inflammatory disease. It mainly affects the spine, the various joints of spine, as well as sacroiliac joints, sacroiliitis. These are the typical of spondyloarthritis. Along with the spinal joints and SI joints, it can affect other peripheral joints as well. And also dactylitis may happen, enthesitis may happen. Enthesitis means inflammation at the site of attachment of the tendons with the bone. And dactylitis, it has been seen, dactylitis is the inflammation, it is sausage digit. It is nothing but inflammation of the flexor or extensor tendons of the finger or toe, or both. I mean inflammation of both extensor and flexor tendon of the finger, finger or toe. It is not very uncommon disease, axial spondyloarthritis. The prevalence worldwide being 0.3 to 2%, and in India also epidemiological studies have shown having the prevalence to the same tune. Along with the joint and spinal spine involvement, extra-articular manifestations such as acute anterior uveitis, this is very typical. It is acute anterior uveitis or iritis. This is very typical of axial spondyloarthritis. Psoriasis and IBD can happen in axial spondyloarthritis. And HLA-B27 is very strongly associated with spondyloarthritis. HLA-B27 gene is directly responsible or causative for this disease, spondyloarthritis. How it causes spondyloarthritis? By various mechanisms. There is these 5 mechanisms have been proposed. Either one or multiple mechanisms can act together. One being arthritogenic peptide misfolding hypothesis is the most popular or most modern hypothesis, which explains the role of HLA-B27 in developing spondyloarthritis, misfolding hypothesis. Others are homodimer formation, ERAP1 interaction, HLA-B27 interacting with ERAP1, and gut microbiome influenced by the HLA-B27 or interaction of HLA-B27 molecule and the gut microbiome. So these are the way HLA-B27 can cause spondyloarthritis. Now let's have a look at the key inflammatory cells and cytokines. Those are involved in spondyloarthritis. Antigen presenting cell, Th17 T cell, and monocyte or macrophage. These are the 3 main players in development in the pathogenesis of spondyloarthritis. We know that this spondyloarthritis is a Th17 pathway disease, and these 3 are the key cytokines: IL-23, IL-17A, and TNF alpha. And in the later part of this presentation, we will see that we use targeted therapy. We target these 3 molecules to treat spondyloarthritis. We have anti-IL-17, we have anti-TNF inhibitors to treat spondyloarthritis, but anti-IL-23 inhibitors are not much effective in spondyloarthritis, but those anti-IL-23 have shown their efficacy in psoriatic arthritis, in psoriasis and IBD. So for some reason, for some unknown reason, it is not very much effective. IL-23 inhibitors are not very much effective in spondyloarthritis. Oh, this is a bit hazy. This is how we classify or diagnose spondyloarthritis, axial spondyloarthritis. First thing is, patient must be having low back pain for at least 3 months, and the age of onset of low back pain will be less than 45 years. And there must be either sacroiliitis in imaging, in X-ray or MRI, with at least 1 SPA features, or there must be HLA-B27 positivity plus 2 or more SPA features. And what are the SPA features? Those include arthritis, enthesitis, heel enthesitis, that is Achilles tendinitis, uveitis, dactylitis, psoriasis, Crohn's disease, good response to NSAID, etc. And also, ASAS has given a classification criteria for peripheral SPA. Some patients do not have axial involvement or minimum axial involvement. They have mainly predominantly peripheral involvement. So, in predominant peripheral SPA, The entry point is there has to be arthritis or enthesitis or dactylitis. And if these patients have at least one of the SPA feature, that is presence of psoriasis or IBD or HLV-20 positivity or uveitis or sacroiliitis in MRI, then those patients may be classified as peripheral SPA. So when we talk about axial SPA, we talk about both non-radiographic and radiographic axial SPA. So what is radiographic SPA, or that is also called ankylosing spondylitis? X-ray is showing sacroiliitis, like this image. X-ray, these are the sacroiliitis joint. X-ray is clearly showing erosions, sclerosis, and pseudo widening because of the erosion of the joint. So X-ray clearly showing bilateral grade 2 sacroiliitis according to modified New York criteria. On the left side, MRI is showing bone marrow edema. In this patient, in this particular case, X-ray is not available, but X-ray in that case was normal, absolutely normal, and MRI was showing MRI is showing bone marrow edema. This side more, and this side, that side also, on the right side less, much less. So this patient fulfills MRI criteria for sacroiliitis. But interesting thing is that we can think that yes, it is early stage. Non-radiographic axial SPA is early stage. MRI is showing sacroiliitis, that is bone marrow edema. Maybe later on they will progress to develop more advanced disease. They will develop bone erosions and they will develop sclerosis, and ultimately radiographic or X-ray will be showing sacroiliitis. But it is not always true. Many times this happens. NR axial SPA, non-radiographic SPA, progresses to ankylosing spondylitis or radiographic SPA, but not always. This progression is not uniform. Many patients remain in this non-radiographic stage for many years. So though basically these two diseases are same actually pathophysiologically, that's why treatment wise also. But there is some slight difference between this non-radiographic and radiographic SPA. One is X-ray is showing sacroiliitis, and the other one X-ray is normal, MRI is showing sacroiliitis. Clinical features are same. Only radiography SPA or ankylosing spondylitis, they have more aggressive features. They have more stiffness of the spine. Progression is more or aggressive in case of radiography SPA, but it is relatively stable or relatively non-progressive in non-radiography axial SPA. But this is not the rule. Prevalence in ankylosing spondylitis or radiographic SPA are more common in male, but in non-radiographic SPA, the male-female ratio is equal. Treatment is similar. Treatment is same in both the groups because these two are the same disease but fall in the different part of the spectrum. So how do we diagnose? First is history and physical examination. Inflammatory back pain history you have to take. Family history, that is history of spondyloarthritis in family, uveitis, IBD or psoriasis, that kind of history you have to take. Laboratory examination, laboratory test, HLV-27 is a must, and ESR CRP. In active case, we will have high ESR or CRP. Imaging, X-ray and MRI you have to order to look for sacroiliitis, and you have to use classification criteria that just we have discussed, ASS, axial and peripheral SPA classification criteria. Now, what are the primary goals in management of axial SPA? First thing is relief of symptom. To eliminate symptoms such as pain, stiffness and fatigue, that is of our prime importance. And maintenance of function, prevention of progression to structural damage of the spine, that is another priority to prevent deformities, minimizing extraspinal and extraarticular manifestation and comorbidities. Maintenance of effective psychosocial function, that is rehabilitation. So initial management, non-pharmacological. Patient education is must. We have to tell the patient about their disease. Smoking cessation, that is also very essential. Exercise and physical therapy, that I am not going to details. The next speaker will be elaborately describe this part. But I would like to mention one thing, that even in patients, studies have shown that patient on TNF inhibitor. They are stable on TNF inhibitor. They are doing well with TNF inhibitor. Even they are subjected to intensive rehabilitation exercise program and patient education. They show improvement, they show objective improvement in BUSDI. Disease activity score has improved. Even though they are previously doing well with TNF inhibitor, but even with exercise program, they are even objectively better with the exercise program. So this is where the importance of exercise and physical therapy lies. Initial management, pharmacological. So we have to start with NSAID. All patients should be treated with NSAID if it is not contraindicated. Adequate trial of NSAID has to be given to all patients. NSAID is the first line of therapy. At least 2 NSAID has to be given if one NSAID fails, and over total 4 weeks this trial has to be given. If it fails, then you have to go to second line therapy. Any NSAID has to may be given. There is no preference of NSAID. Continuous NSAID treatment is preferred over on-demand NSAID. So whether patient pain persists or not, this NSAID has to be taken continuously, continuous for 4 weeks or something, or even more than that. And another important point is if patient has IBD, in those cases we have to use NSAID with caution, because NSAID in IBD patients may cause exacerbation of GI bleeding. So we have to use in caution. Maximum 2 weeks continuously we can use NSAID in such cases. Steroids. What is the role of steroids in spondyloarthritis patients? Systemic steroid not recommended. Imaging guided SI joint injection can be given. Active peripheral arthritis, IS, intraarticular steroids, and local steroid injection in the active enthesitis better to avoid. So if initial treatment fail, about the extra-articular manifestation, if uveitis is there, methotrexate, salvagine may be tried. For IBD, methotrexate. For Crohn's disease, salvagine. For ulcerative colitis, those are the preferred choice. Psoriasis, methotrexate. Enthesitis, dactylitis, methotrexate. If the initial treatment fails, then we have to move to the second line treatment, and those are nothing but biological treatment and targeted synthetic DMARDs. When we should consider if there is disease activity is high, that is ASDAS more than 2.1 or BUSDI more than 4, when the baseline treatment, the first line treatment has been tried and there is positive rheumatologist opinion, rheumatologists think that patient should be subjected to biological DMARD or targeted synthetic DMARD. So what are the options? Among TNF inhibitors, adalimumab, golimumab, infliximab, satralizumab. These are the monoclonal antibodies against TNF. Etanercept. This is this is also TNF inhibitor. This is not monoclonal antibody. It's a fusion protein against TNF. And IL-17 inhibitors are secukinumab, ixekizumab, and bimekizumab. JAK inhibitors, among these, tofacitinib and upadacitinib. In special situations like recurrent uveitis, monoclonal antibodies against TNF inhibitors are preferred. In active IBD, preference should be given to monoclonal antibodies against TNF inhibitors and JAK inhibitors. In patients with significant skin psoriasis, IL-7 inhibitors is preferred. Now, when to continue with the biological DMARDs or targeted synthetic DMARDs? If after 3 weeks of treatment with biological DMARDs or targeted synthetic DMARDs, if patient shows improvement of ASDAS more than 1.1 or BUSDI improvement more than 2, then patient has significantly improved and that treatment may be continued. But if patient does not show this kind of improvement, then we have to go to the phase 3, that is a second biological DMARD or another JAK inhibitor. So, but before going to the phase 3, we have to assess whether it is the true failure or not, whether drug compliance is okay or not. So that part we have to assess. So a second TNF inhibitor can be efficacious, even the first TNF inhibitor has failed. And IL-17 therapy has proven efficacy in patients who had failed TNF inhibitor for the first time. JAK inhibitor may be effective in case of TNF inhibitor inadequate responders. So even TNF inhibitors or adalimumab has failed, tofacitinib or upadacitinib may work in such cases. So if a patient has sustained remission, tapering of biological DMARD can be considered. So what is the definition of remission? As does inactive disease or low disease activity. Sustained remission means at least 6 months a patient should be in as inactive disease, and complete discontinuous demand has shown that flare of disease in many of the cases. So slow tapering of biological demands may be done, and this can be done with dose reduction or increased interval or spacing. And predictors of flare in during tapering treatment will be raised inflammatory markers and definitely shared decision making. So thank you. So next part, that is the rehab part, will be dealt by Dr. Arup.
থ্যাংক ইউ। এটা খুব প্রাউড মোমেন্ট আমার কাছে যে আমার মেডিসিনে যার কাছে হাতে খড়ি হয়েছিল প্রফেসর অরূপ কুন্ডু, এনআরএস মেডিকেল কলেজে, উনি চেয়ারপারসন। ওকে, আই এম স্টার্টিং মাই স্পিচ। That is supervised rehabilitation program for patients with spondyloarthropathy. So what are the spondyloarthropathy? Already it is discussed. There is a heterogeneous group. There is ankylosing spondylitis, reactive arthritis, juvenile chronic arthritis, undifferentiated SPA, psoriatic arthritis, etc. Next is current classification already discussed, ASS criteria already discussed, pathology of enthesis already discussed. There are different spectrum of axial involvement where there is a gradual squaring of the vertebra to bamboo spine, stiffness of the spine, sacroiliitis, etc. Next, imagine already discussed. And extra-articular manifestations, dactylitis, anterior uveitis, enthesitis, and restrictive lung disease. And spectrum of AS. Now the spectrum of AS, first it starts with low back pain, stiffness, fatigue. Then it gradually goes to the spinal limitation, functional limit, and night pain. And ultimately there was spinal immobility. Extra-articular manifestation, ocular skin nail enthesis, ocular manifestation, skin nail reactions, enthesis, chronic uveitis, inflammatory bowel disease, aortitis or restrictive lung disease, heart block. And disease progression from sacroiliitis to hip involvement, spondylitis, to ultimately peripheral arthritis or bamboo spine. Now the challenge is where to stop these progressive symptoms. So if we stop this progressive symptom in the first line, then we can probably save the patient and save the deformities, save the problems. So what are the impairments in spondyloarthropathy? Pain, fatigue, aerobic capacity loss, sexual dysfunction, decreased strength, decreased range of motion, decreased mobility, gait abnormalities, postural changes. So for the assessment of spondyloarthritis, we from the Bath Ankylosing Spondylitis Society, they have some parameters for the functional assessment. BAS-5 for spinal mobility, BAS-MI chest expansion, for pain NRS or VAS. Patient global can be assessed by the global disease activity last week, NRS or VAS scale. For the stiffness, duration of morning stiffness and spine of last week for NRS or VAS, and the disease activities BASDAI or ASDAS. This is a small format for the BAS-5. This is the numerical rating scale. This is BAS-MI and this is BASDAI. Now the management is pharmacological and non-pharmacological. Pharmacological already discussed. For the non-pharmacological sense, there is patient education, exercise, modalities, occupational therapy, biopsychosocial measures, orthosis, assisted devices and vocational rehabilitation. And next is aims of non-pharmacological management. First is decrease pain, increase mobility of joints affecting like spine, hip, thorax, shoulder, etc. Decrease deformity, increase chest expansion and vital capacity, attention to posture, increase physical endurance. So there is 2019 update of the ACR guideline. They said ki this is a physical therapy, active physical therapy over the passive is important, and land-based physiotherapy or land-based physical exercises are good over the aquatic therapies. Next is ASA's Euler recommendation for the management of axial spondyloarthritis. They said the recommendation focus on the non-pharmacological treatment, which in axial spondyloarthritis is of prime importance. All patients should receive education about the disease as the starting point of self-management to empower and involve them as active partners in their care. Patient education in broader terms should include information on the disease, its symptoms and recognition, disease course, treatment options and prognosis. Exercise is a cornerstone in the management of AXSPA, which demonstrate the benefits in the disease outcomes independent of the pharmacological treatment. While exercise in general should always be part of the disease management, evidence from qualitative studies shows that adherence is higher if it is supervised. And physiotherapy, specifically supervised exercises, has also proven to be more efficacious than home exercise. So, this is a systemic review, says the effects of the exercise therapy in axial spondyloarthritis. They show exercise therapy improve BAS5, BAS-MI, BAS-DI, ASDAS, VO2 peak, pain, fatigue, etc. in a significant way. But however, no significant benefit was found in chest expansion, CRP or ESR outcomes. So the conclusion is exercise therapy is an effective strategy for improvement of disease controls and symptoms relief in patients with SPA. So a supervised rehabilitation program is devised which consists of the joint protection technique, posture care, multimodal exercise program, pain control, group therapy classes, energy conservation technique, workplace modification, suitable recreational activities, patient education, etc. And there are some home exercise program which mainly are the multimodal exercises, lifestyle modification, patient education, suitable recreational activities and pain control. So we have devised a study to assess the efficacy of supervised rehabilitation program in patients with axial spondyloarthritis. The study design, we have total 60 patients. They have classified into control group of 30 and intervention group of 30 by the randomization technique. And first there is baseline measurement of the parameters, then the control group go to the home exercise program and the intervention group goes to the supervised rehabilitation program. And after 3 months we repeat the measurement. So what are the intervention we have proposed? For the supervised rehabilitation program, supervised multimodal exercise thrice weekly, aggressive lifestyle modification with regular supervision thrice weekly, group therapy classes thrice weekly, counseling weekly, supervised joint protection technique weekly, supervised energy conservation technique weekly, active environmental modification weekly, cognitive behavioral therapy for pain management weekly, followed by session, and the physical modalities for pain management as required. For the home exercise program, there are multimodal exercise program demonstrated monthly, lifestyle modification advices monthly, counseling monthly, Environmental modification advices monthly, joint protection advices monthly, energy conservation advices monthly, physical modalities for pain management in outpatient basis as required. So this is the main format for our study. So multimodal exercise program is starting with the warm up, 10 minutes step exercise and 5 minutes stretching exercise, then main period of 20 minutes of step exercises, and then cool down for 10 minutes of pulmonary exercises along with 5 minutes of stretching exercises. These are the stretching exercises, and these are the stretching exercises protocols. So the step aerobic exercises, and next the step aerobic exercise protocol. Now pulmonary rehabilitation, very important, inspiratory respiratory muscle training, deep breathing exercise, breathing techniques, incentive spirometry, and inspiratory muscle training is emphasized. Patient education program, patient and family member awareness, lifestyle modification like stop smoking, bed use of farm beds, and don't stay 30 minutes or more in a same position, and then suitable recreation activities like badminton, volleyball, swimming, etc. Group therapy classes are emphasized. Occupational therapy, postural care, workplace modification, fall prevention, energy conservation techniques, joint protection techniques, adaptive devices, driving instruction modification, environmental modification. These are the posture care advices. Home and environmental modification. Fall prevention is also important. Skid resistant shoes, grab bars for the shower and toilets, shower sheets, raised toilet seats, floor lighting at night, avoid slippery surface. So these are the energy conservation techniques and joint protection techniques. Now cognitive behavioral therapy also make a good role in this supervised technique, where the patient reconceptualized their pain experience, were taught pain coping skills, and give opportunities for behavioral rehearsal and guide practice. The knowledge and skill obtained through the process was then applied during a pain episodes or flare of disease. So modalities, we avoid deep heat modalities like ultrasound, sort of diathermy, but moist heat, cold application, hydrotherapy is advocated. Adaptive device like wide view mirror, prismatic glasses, revolving chairs, Velcro strap for shoe, and shoe horn for easy to wear shoe. Next, electrically operated devices in the kitchen, long reach handles, lighter, wide handle utensils, forks, spoons can be used. For vocational consideration, educational level, work history achievements, physical function level, and social psychological adjustments are done so that patient can be relocated in his profession. So there are the studies published showing the BASFI and pain improved after the supervised rehabilitation program, and spinal mobility, BASMI and chest expansion also improved after the supervised program, and there are BASDA also improved after the supervised program. So in conclusion, early diagnosis, active patient involvement, think rehab early in the disease course, optimal pharmacologic and rehabilitation measures is important. This is my references. And so I am prescribing exercise, think of it as a stress field that takes 30 minutes to swallow. Thank you.
Thank you, Arup. Please take the seat. Now the house is open for question, one or two questions.
I think since we are running very short of time, so okay, one question.
Yes, definitely. HLA deficiency is not mandatory for diagnosis of spondyloarthritis. If there is sacrality in the MRI, so and it.
I told HLA B27 negative NR AXST.
NR axial SP, they will be having sacroilitis in MRI, but X-ray will be normal. X-ray SI joint will be normal, but sacroilitis in MRI. Radiographic means X-ray. X-ray is not showing sacroilitis. MRI is showing sacroilitis.
Thank you so much.